All right, let's dive into a case that every radiologist and orthopedist will find interesting. We've got a 10-year-old boy presenting with a limp and left-sided hip pain. Right away, you start thinking, what could be causing this? Could it be something benign, like transient synovitis? Or could we be dealing with something more serious, like Legg-Calvé-Perthes disease? So the first thing we do, of course, is take a look at the ultrasound. What do we see? Well, there's no joint effusion, which rules out some acute causes like transient synovitis or septic arthritis. This already starts guiding us towards something more insidious, something chronic. Next, we move on to the plain radiograph of the pelvis. Here things get more interesting. On the left side, the proximal femoral epiphysis is showing some abnormal features. We've got sclerosis, flattening of the epiphysis, and even a hint of subchondral lucency. These findings are subtle, but enough to make us think of a vascular necrosis. The joint space is slightly widened, but no slipped capital femoral epiphysis. CFE is visible here, and no acetabular changes either. So, we've started to narrow down our diagnosis. Now on to the bone scintigraphy, a 99 millitc MDP scan. This test is excellent for confirming decreased blood supply to the bone, and in this case, we see exactly that. A photopenic area in the left proximal femoral epiphysis, which confirms our suspicions of a vascular necrosis. Putting this all together, we land on the diagnosis of Legg-Calvé-Perthes disease. Let's take a step back and talk a little about what Legg-Calvé-Perthes disease, LCPD, is. It's an idiopathic avascular necrosis, or osteochondrosis, of the immature proximal femoral epiphysis. What causes it? The leading hypothesis is that the blood supply to the femoral head gets interrupted repeatedly, causing the bone to die. This is hypovascularity due to repetitive vascular insult. The disease is rare, affecting about 1 in 20,000 children, and it's much more common in boys with a male-to-female ratio of 5:1. The age range for onset is typically 3 to 12 years, with a peak incidence around 7 years old. And while it's usually unilateral, in 5 to 10% of cases, it can be bilateral, although this usually happens in an asynchronous fashion. When it's bilateral, we often use the unaffected side as a reference for what's normal. This condition typically starts with a painless limp, which can eventually turn into hip or knee pain as it progresses. On clinical examination, you'll find limited range of motion, particularly with abduction and internal rotation. Let's dive into the radiographic features. Early on, plain radiographs can be tricky because the changes are subtle. Lateral views are often more helpful than the AP projection, but what you're looking for are signs like sclerotic lines, flattening of the femoral head depressions, and acetabular flattening. As we saw in this case, those changes can be present, even if subtle. Now don't forget about ultrasound. It's great for picking up early joint effusions, which are often a sign of early inflammation or damage, though we didn't see one here. When it comes to more advanced imaging, bone scintigraphy and MRI are our best tools for diagnosing and characterizing the early stages of this disease. These modalities are much more sensitive than plain radiography, and they don't expose the child to ionizing radiation, which is a big plus. What do we see on MRI? In the early stages, you'll notice T1-weighted low signal in the subchondral bone indicating a subchondral fracture. On T2-weighted images, you may see bright fluid signal, either as joint effusions or fluid in the fracture line. The necrotic bone itself typically appears dark on all sequences, making it easily distinguishable from healthy bone. MRI is also great because it gives us detailed information about the ossified and non-ossified structures of the pediatric hip joint, helping with both diagnosis and management. We're also seeing some exciting developments with dynamic post-contrast MR perfusion and diffusion imaging, which are starting to be used in some centers. These can help assess the blood supply to the femoral head in real time, but they're not yet widespread in practice. Now let's talk about the natural history of Legg-Calvé-Perthes disease. Initially, there's reduced blood flow, which leads to sclerosis and flattening of the femoral head. As the disease progresses, you can see fragmentation and subchondral fracture, followed by a remodeling stage, where the bone starts to heal and be replaced by normal bone. Even though the bone gets replaced, its normal growth pattern is often disturbed, leading to abnormal morphology. You may end up with coxa magna, which refers to that characteristic broad, mushroom-shaped femoral head with a shortened metaphysis and an irregular acetabulum. How do we treat this condition? The main goal is to reduce pressure on the remodeling femoral head, allowing it to regain a normal shape as much as possible. Treatment can either be non-surgical, involving bracing, or casting, or surgical, where an osteotomy is performed to reshape the joint and improve its congruency. One key point to remember is that earlier onset of the disease usually means a better prognosis. Kids younger than 8 years old tend to have more successful outcomes because their bones are still highly adaptable and can remodel more easily. On the other hand, children older than 8 have a higher risk of long-term complications, like premature osteoarthritis, because their bones may not reshape as effectively. Now, you may be wondering about the differentials for a child presenting with hip pain and a limp. You have to think about conditions like, we didn't see any signs of trauma here. Transient synovitis, often seen in younger children with joint effusion, but our ultrasound didn't show an effusion. Septic arthritis. This usually presents in a toxic child with a fever, and hip aspiration is the gold standard for diagnosis. Slipped capital femoral epiphysis, SCFE, usually seen in adolescence and characterized by the femoral head slipping off the neck. We didn't see that here either. And let's not forget inflammatory conditions like juvenile idiopathic arthritis or metabolic causes like sickle cell disease or leukemia, all of which can present with joint pain in children. To wrap things up, the most important thing here is to make sure this child is under the care of a pediatric orthopedic team who will decide the best course of action based on the progression of the disease. It's crucial to keep an eye on both hips, given the possibility of bilateral involvement. That's Legg-Calvé-Perth's disease, a complex but fascinating condition that underscores the importance of early diagnosis and careful management to ensure the best outcome for these kids. If you've encountered cases like this or have any pearls of wisdom from your own experience, drop a comment below. And as always, don't forget to subscribe for more cases and insights from the world of radiology.